Welcome everyone to the Africa and COVID-19 webinar series, The Role of Digital Health and Telemedicine. Today, I'm going to be our moderator today. My name's Rebecca Weintraub. I'm a faculty member at Harvard Medical School in the Department of Global Health and Social Medicine, a physician at one of our Harvard teaching hospitals, and thrilled to be here with our distinguished panelists to discuss this very important and timely topic about the ecosystem needed and the promise of digital health and telemedicine in the midst of the COVID-19 pandemic. We are going to start today with just a few webinar housekeeping. Each webinar will start with the slide you're seeing about statistics that are affecting the African continent, African COVID-19 by the numbers. And we will also be initiating a poll that Li Ming will post, and we'll hope you'll participate in the poll, and we'll announce the results at the end of the hour. Here we are, the poll. Have you used a digital health or telemedicine provider since the start of the pandemic? And thank you everyone for participating. We'll share the results at the end of the hour. So our topic today is quite timely, as we all have been facing the effects of the COVID-19 pandemic globally. It's accelerated the need for ourselves as healthcare providers and our patients to engage in digital services in the midst of lockdown orders and observing physical distancing measures. We've known that technology was critical to contact tracing in the past, modeled on efforts in response to Ebola and Lassa fever. And we see this as an essential step in reopening economies prior to the deployment of a widely effective vaccine or the vaccine portfolio ahead. So thrilled today that the Center for African Studies have been able to bring together a tremendous panel. I'll introduce our panel. Tania Holt is a partner at McKinsey & Company. She leads McKinsey's healthcare activities across Africa, motivated by a personal passion for extending access to affordable and high quality healthcare services and products. She works at the intersection between private companies, governments, and social stakeholders across the continent and has on-the-ground experience over 20 countries to date. Our second panelist today is Jacques Mundo, who's the thoracic and cardiac surgeon at Beth Israel Deaconess Medical Center and an adjunct faculty member at the University of Ghana. His research interests include a biomedical device innovation, digital health, and artificial intelligence technology. And he'll actually be providing several demos for us today. And Eugene Richardson, who's an assistant professor of global health and social medicine and assistant professor of medicine at Harvard Medical School. His focus has been on the biosocial approaches to epidemic disease prevention, containment, and treatment in sub-Saharan Africa. He most recently was in Addis Ababa supporting the African CDC COVID-19 response, and then spent time this summer in West Africa in the midst of the response. Apologies today, Minister David Senge was unable to make it as he's pulled into a last-minute meeting and sends his regrets. Welcome all to our panelists. Thank you for joining us today.
Thank you.
So many of us have read and consumed the Lancet report that reminded us that there's a tremendous moment here, an ecosystem that could be developed to ensure the promise of global digital health leads to an improvement in service delivery. We also know there's critical bottlenecks that need to be observed and understood as these technologies are rolled out in the midst of the response. We're going to try and engage in a pretty wide-ranging conversation in 55 minutes. And we're going to start actually with a demo. So we think about the promise of the technology ahead. Thank you, Jacques, for serving to get us involved in the excitement and things that you're developing, and you see the promise ahead. I'll pass the baton to you.
Thanks, Rebecca, for the kind introduction. And thanks to the Harvard African Center for inviting me on this panel. And thank you to our audience for tuning in. So I would like to kind of give a broad landscape of how we can use some of these digital health technologies to improve access and delivery of care in sub-Saharan Africa. So my focus is obviously on cardiology, since I'm a cardiac surgeon. So I would like to kind of describe some of the pathways through which we can scale some of these technologies, perhaps to develop a telecardiology program or to develop perhaps a maternal health program. So from the cardiology standpoint, one of the biggest barriers to cardiac care is diagnosis. And as we know, there are not many high-end ultrasound devices in many of these sub-Saharan African countries. So portable ultrasound has become a useful tool for quick screening, and perhaps as those devices get more complex, we might be able to make some on-the-ground diagnosis. So today I want to show you a device which is a point-of-care ultrasound device, but unlike many of the current devices that we see on the market, this is a diagnostic tool. So it's also able to give you what we call continuous wave and pulse wave Doppler, which is good for screening for rheumatic heart disease and actually diagnosing rheumatic heart disease. So conceivably, it's possible to have a physician or even a community health worker use a device like this with their iPhone, Android tablet, and screen a patient, acquire the images using telepresence technology, and then send those images through a cloud platform for a remote read. It can be a remote read that's done in country, or it can be sent out country for diagnosis. The beauty of such devices is that once you've created a library of images, it's possible to build artificial intelligence tools to make the diagnosis right at the point of care. So currently we are piloting some of this technology in Ghana, where we are able to make some of these point of care diagnoses, have them read, and then sent back to the to the original hospital. In due time, it's possible to actually train a mid-level, maybe a community health worker, to do those ultrasounds under the guidance of telepresence technology, and that those community health workers can now go out into the rural community hospitals to actually screen those patients. Perhaps using AI, a diagnosis could be made at the point of care, and the treating physician can actually start implementing care. So these are some of the, this is the ultrasound technology that we can also use also for maternal health, right? To do quick screening of pregnancies and then direct care as appropriate. If we think that this is a high risk pregnancy, we can direct that care to a more specialized hospital setting. So in brief, these are some of the technologies that can be used, at least from the cardiology standpoint. And for those of you that are interested in wearables, I'm sure most of you have some form of a Fitbit or an Apple Watch device. It's also possible now with some of these devices, which I have one on my wrist, that can actually do a blood pressure measurement, an oxygen saturation measurement. And again, this is very useful for chronic care management in the rural setting. The question though is, how do we build the countrywide digital infrastructure to enable all these devices to be able to send the data, and where does the data reside? So I'm hoping that as we go through this panel discussion, some of these ideas and thoughts will be shared broadly on how we can scale this from pilots to national implementations. Thank you.
Many thanks, Jacques, for starting us off in such an exciting beginning. And I think we're also aware of the implementation bottlenecks to move from the promise of the invention, from the innovation, into a scaled national service. And Gene, we'll kind of, bring the baton to you for a moment to think through and kind of get your discussion about how do we think through the shift towards digital health and telemedicine, and your previous experience. Is this possible? What are the bottlenecks that we'll likely face from your previous experiences?
Sure. Thanks so much. And thanks for the center for inviting me. The promise is certainly there, as Dr. Kpodonu just showed us. Other places I've seen the promise include other radiological modalities, from sending X-rays, and even some getting into CAT scans for reading elsewhere, whether inside the country or abroad. And even the greater promise of ultrasound for not just cardiology and maternal health, but people I've worked with will debate now whether the ultrasound is actually a better lung diagnostic tool than the X-ray, and they will show you how they can look at everything from pulmonary edema to pneumonia to TB with just as much sensitivity. So if we have that, enable people to do that at the bedside, that can be truly revolutionary. I would say, as far as some of the bottlenecks that I've come across, they're more structural, in the sense that, for example, last year I was working with the WHO in DRC on the Ebola outbreak there, the one that finished, not the one that the new one in Equateur. And what we saw is that we had an Ebola vaccine, and people were very reluctant to take it. I remember going into villages of, say, 200 people, and maybe 8 people would accept it. At the same time, while there was focus on Ebola, the vaccination coverage for measles dropped, and more children ended up dying from measles than from Ebola during that time. And this may be way upstream, but I would go into WHO meetings and say, we need to think about things like reparations at the same time we're talking about these things, because this is, people's, when they don't accept vaccines or new technologies, it's not because they don't understand them. People will point to, oh, these conspiracy theories, they don't believe Ebola is real. I think what's happening there is that there's really, it's not ignorance, it's illusion of depredation. It's the understanding of 200 years of extractive economies, that it's unclear whether this is part of that, whether these new technologies are part of the several centuries of extraction, that whether it was humans that were extracted, or natural resources. And I think rightfully people think that. And until colonial legacies are repaired, that some of these technologies might be putting the cart before the horse. And so we have a Lancet Commission on reparations and redistributive justice right now that is looking at, one of the sections is on DRC and how the US and Belgium owe a combined several $1 trillion for the atrocities there. And what would the landscape look like for these new technologies if there were repair of these legacies? So just put that out there.
Thank you so much. we can imagine the dimensions of this conversation to ensure the system has the infrastructure to absorb this level of innovation. So we've almost gone from one pole to the next. So maybe just to bring us to kind of, today, the systems and the infrastructure that's available today, Tania, I'm just curious, kind of your observations across the continent, the complexity of asking providers to provide digital health and telemedicine in the midst of the pandemic, and the challenges and opportunities you see across the continent.
Yeah, and first of all, thank you very much for the invitation and opportunity to be here today. Two observations on this. I think, there's no doubt that COVID-19 has certainly accelerated the adoption of digital technology. I do think we have to ask ourselves a question: has the acceleration been as fast as we've seen in other parts of the world? So when we're looking at and hearing some of the data coming out from, for example, the NHS, which has essentially kind of turned the number of consultation from in-person onto digital platform in a 4-month period, what they actually expected to achieve in 10 years, we have to look at the numbers we're achieving in an African context and saying, are we making the same quantum leaps? So I think while we should be celebrating, rightly so, that we have adopted many technologies at an accelerated pace also over the last month, I would challenge us on the question, is it fast enough? And I think to that spirit, there was an interesting study done by the EIB a few months ago, really looking at how have the countries been able to implement digital solution during COVID-19. And there's a couple of interesting, they essentially came out with 3 categories. They kind of said, there's 22%, and this was self-surveyed kind of assessment by the countries themselves, with whatever biases that bring. But ultimately, 22% of the countries were saying, actually, we've been very slow. We've probably done, none or at best maybe 1 or 2 adoptions. And typically the adoptions that we would see are related to communication and engagement with the population. And that is also because those are often tools that have been available for those governments beforehand from other health programs, maybe, TB programs or broader cardiovascular programs, whatever is of importance in those particular countries. Then you kind of have a middle part of 37% of the countries that say, we've probably done 3 to 4 things, and we're able to do it on a couple of dimensions. So not only have we done it on communication, we probably also done some of it in terms of consultation, or as we think about contract tracing, we have set up call centers that we have staffed people towards and so forth. And then you have a 41% that are actually saying they've had a significant usage. And that's, of course, a group to celebrate. And I think many of us have heard brilliant examples coming out of Rwanda and South Africa of what was recently launched by President, His Excellency Cyril Ramaphosa down there in terms of some of those different apps. The thing, I think we always as health people need to make sure that we work in collaboration with the broader system and the broader governments. And so the other point I just wanted to note is that when you look at the categorization of those 3 big categories I just laid out, there's actually a really strong correlation to broader human capital development. So when you look at what the World Bank has put out on their HDI index, there's a positive correlation between the countries that are able to adopt digital solution and how well they're performing on a human capital development agenda. And so as healthcare people, I think that means that we also, as we think about this digital health agenda, really needs to engage with ministries, with actors outside of healthcare, because any investment into human capital development ultimately is necessary to make sure that we get a high adoption of the digital solution as and when they are put into place. The last thing, Rebecca, I just wanted to make a comment on as well is really, and for us to think through, what is an e-health universe and what is kind of digital health. And with that, I mean, when we think about the e-health universe, this is perhaps a little bit of the more historical way of thinking about some of these things. It was very much centered around the doctor and the doctor as the center of it, and having, medical records, being able to access different information points and so forth, but really the system built around the medical doctor. And then when we think about digital health, one might, argue that loads of that is around empowerment of the individual and the patients themselves. And all of a sudden, a bit of a human-centered approach. Also, we put the patient in the middle, and we're trying to empower the patients with access to the nurse or the doctor on the phone, the medical record on the phone, and many other things. What I think is really important we think about is, what are the connection points between those two? How are we not making separate investments into e-health system and digital health, but not thinking about those connectivity points between the two sufficiently?
Thank you so much, Tania. You're really kind of helping us establish what are these bridges as our practitioners and leaders on the line are struggling with the daily decisions of where do I invest? How do I ensure my workforce is protected and equipped? I thought we could just maybe spend a few minutes talking about contact tracing. So I do think some of the themes Tania just speak about how a minister of health, for example, is saying for a non-pharmacologic intervention like contact tracing, I need a flow of data. I need to preserve the privacy of the data. It needs to flow into different systems. And, curious, your early take as you're watching countries attempt to roll out contact tracing. We can mention in the US, this has been a very heterogeneous service delivery of contact tracing, which if we have a few minutes we can reflect on. But Jean, I'll pass the baton to you to kind of give some early thoughts of your reflections on contact tracing.
All right, thanks so much. Yeah, you know, you're right. The contact tracing is there's quite diverse practices around the world. So you see some of the countries in Asia that have been doing it with the cellular technology, and it's been working well. And then in the US, where it's been more of a hybrid, not really with cell phones tracking, but with people calling instead of doing the gumshoe door to door, which with an aerosolized disease is important to protect the contact tracers. And then you have something like Ebola, where in West Africa and DRC, it was mainly, you know, door to door, people going, you know, good old fashioned epidemiological intelligence. There was some attempts to do the phone contact tracing with Ebola in West Africa. I believe they started with Liberia, and Liberia turned it down because of the privacy issues, and then they did it in Sierra Leone. But I didn't hear of any results until they were published in academic papers, you know, many, many months later. So they weren't useful on the ground. And then when they did come out, they basically just said, oh, it looks like during the lockdowns, people stayed at home, which was obvious to people on the ground. So, you know, in places where phones don't cohere with people, they either have 3 phones, or they share them, or they leave them at home when they go out because, you know, I can imagine a situation where if people were told they were being traced, they would just leave the phone because of the sort of trust issues that have historical legacies that I was talking about in DRC. And so I think, you know, when we talk about the promise of some technologies, we have to look at the, you know, whether across the board, all of them have such promise. And I have not seen that for at least the use of mobile phones and contact tracing. I've seen it more useful for academic capital for, you know, foreigners than for actual work on the ground. And you know, in fact, a place like Liberia, where people like, you know, Dr. Masoka Fala were hailed for helping contain the outbreak, his was going into communities where he was known, and you know, going door to door, and you know, really you know, establishing a communal approach, which is paradoxically easier with a disease like Ebola, even though it's more lethal. It's not aerosolized, so you can go with PPE door to door. It becomes harder with COVID, and so you know, our approaches to that have to be tailored. There was a slide shown at the beginning of the number of cases throughout the continent, and that's another part of the technology conversation. You know, those numbers are at, I would say, at least 10 times lower, maybe 20 times lower than what's really out there. And it has a lot to do with availability of testing. It's not that the resources weren't there. When I was in Addis with Africa CDC, they had the money to buy tests, but they were being outbid for PPE and for tests, because of, again, these legacies of, you know, parentheses, neo-colonial economies that, you know, prioritize certain places and certain people doing transactions over others. And so I think it often comes back to repairing these legacies if we really want some of these strategies to work. You know, Dr. Kpodonu's bedside, you know, instruments, that is a way to transcend it. But for many of the technologies, I don't think there is a way to really use them effectively without repairing some of these legacies that I was, you know, discussed earlier.
Many thanks, Jean. Jacques or Tania, would you like to respond?
Okay. The one thing I might just say or add to this, I think, you know, certainly digital technologies and tools are one way of doing this. What we also, though, see being employed on the continent is community healthcare workers. It's a really, really important part of how we think about the health workforce. And in particular, because, you know, we've been talking a little bit about trust and how trust is built between authorities and communities and so forth. But when community healthcare workers are recruited from within the community, we see a much higher use of masks, for example, rather than just communicating to people with text. So I think to a large extent, we also really got to think through digital doesn't have to be either or, sometimes it's also an and. And so when we see in Kenya that more than 63,000 community healthcare workers have been trained and reach more than 5.5 million households, likewise in Nigeria, more than 7,000 community healthcare workers, predominantly for the rural areas, it's an important bridge and an important tool in what will be ultimately a very complex toolkit that each government will have to figure out. And I think, as Rebecca, as you were also saying from the beginning, there's huge variation in quote unquote the success of actually doing the contact tracing. I think in some of the American states is ranging everything from kind of 3% to 6%, the various jurisdictions' ability to actually trace a case back to a known positive case. So it's important that we track the different KPIs, but I do think that we should really leverage the community healthcare workers as an important piece. And sometimes that's with and without digital tools, and in particular for the rural areas. As the epidemic continues to evolve and we'll see more and more cases in the rural areas, the kind of tools that we will need in our toolkit will need to vary.
To you, Jacques, would you like to respond?
Yes. So I agree with Tania and Jane's response. I think Africa is a continent of paradox, right? Because when you look at mobile money, for example, right, it's widely adopted in Africa. In fact, most transactions, today are done through mobile money, and Africa is leading in the use of using mobile money. So I think that there is a role for leveraging what's already been known to work to develop some of these digital health tools. I also believe that some of these tools need to be co-created with the community, meaning, it's difficult to take a digital health app that's created in the US or in Europe and then, go to a country like Ghana and say, hey, here is an app that will allow you to do remote monitoring or measure your blood pressure, use it. I think most of these tools need to be co-created with the communities. We need to identify how, for example, do you manage your hypertension in a clinic? We need to watch the flow of patients, the flow of how does the physician interact with the patient or with the community health worker or with the nurse. And then we need to build those tools around that flow. Once we do that, I think there's going to be a higher adaptability of those tools. And for those that don't have sophisticated phones like a smartphone, we need to use, text-based, approaches like, simple text or WhatsApp, that kind of technology. So I think if we co-create those technologies with the community, I think there might be a higher yield of adoption and a higher yield of trust. So that would be my take on how we should leverage digital tools in sub-Saharan Africa.
Many thanks. Oh, Jean, yes, please.
I just want to add one more thing and throw it back to you, Rebecca. Another example I was thinking of, regarding what I was talking about with the Africa CDC, we can think about using digital technology with the rollout of the, future COVID vaccines and helping tally and track. But, the focus on that really disguises what is probably going to be the reality that rural Africans will be the last to get such vaccines. So maybe you could talk to us about some of the equity work you've been doing on COVID vaccines.
Thank you. In a moment, I think Tania, please jump in.
Yes, so I think, first of all, there's, I think we're at a good point almost to celebrate a little bit, given that the announcement came out just a few days ago on the COVAX facility and with the more than 150 countries that have signed up. Of course, we're still missing a few of the self-financing African countries but I guess there is still a little bit of time for everybody to get on board. But that's a huge step forward in terms of equitable access to vaccine and making sure that Africa can and will access the vaccine at the same time as many of the self-financing and higher income countries. I think there's a pause for celebration within the global public health community. Now, that's of course only one step of the equation. There's loads to be done still, in particular as it relates to the normative guidance on how that vaccine will be distributed and allocated within the countries, and making sure there is a high degree of self-determination within the countries as well, based on well fact-based and scientific advice from the broader community, and of course within that Africa's CDC plays a very important role. However, the point that I may just want to point to a little bit is the downstream. It's the delivery challenges. So the initial uptake and scale up of the vaccines. We're going to be dealing with an unprecedented program we've never seen of sorts. I think most of the African countries have, as many other countries in the world, to be honest, have predominantly the experience comes from the EPIs and the children vaccination programs. And the kind of people and population groups that will need to vaccinate here is very different. We'll also need to be doing a lot more planning under uncertainty. And so typically we know everything about the vaccine. The TPP is very clear. We know exactly what cold chain we need, how it needs to be prepped and so forth. All of these things we don't know, and we need to probably be ready for some of the first vaccines under emergency use authorization towards the end of this year. And within that, perhaps as we think about digital technologies and tools, there's many things that need to be done. Many don't require digital, but many can be solved with digital. When we think about the vaccine, most likely we'll need 2 doses. And so that means that identification of people, so when people come in, we need to know who they are when they receive the vaccines, so that we can then make sure that they get the second dose as well. Those are things that are absolutely, ripe for innovation, and where the digital technologies can have a huge impact. But it's also, quite frankly, more basic thing is we're imagining maybe some of these vaccines will require UCC, so ultra cold chain, and there might only be a few locations within a country. And how are we going to manage the flow of people? You can imagine you actually need maybe sensors to make sure that the flow and crowd of people and the queuing doesn't put people at risk when they come to receive their vaccine, that it's proper space. These are, again, things that digital technologies can absolutely help with, but they're not obvious innovations that we would just think about if we only looked at the current immunization programs that we have on the continent or across the world. So I think it's really important here that we get local innovations. And one of the things that I am a strong believer in, if we think about the broader international community that have set up the ACT Accelerator sitting under WHO, there's a health system connector in there that's supposed to be supporting vaccine, therapeutics, and diagnostic as that get rolled into the various countries. How do we make sure that those health system investments that will be coming from the international community actually have a significant proportion of digital innovations in there, and the digital innovations that are coming from Africa by African entrepreneurs and African companies that truly understand the challenges and also the opportunities to leapfrog within a local context.
Thank you. Gosh, we could unpack and spend literally hours just, speaking about this topic, and we'll ask the center.
Rebecca, can I make one last comment?
Oh, yes. I'm just going to frame 1 second, Jacques, and then I'll hand it to you, because I think what we're seeing and why this topic is so fraught is an unprecedented investment in the discovery. So billions of dollars of nation state dollars that have gone to procure doses of the vaccine and to ensure that doses are received by a political boundary has not in parallel led to this type of investment, Tania, just to the service delivery models that you've suggested and the innovation needed. So in many ways, we're looking to your advice as panelists, where should those investments go? If those dollars were made available by multilaterals and others, if the ACT Accelerator was funded as needed, what types of services would you recommend we make in digital health and telemedicine to prepare for vaccine delivery? Back to you, Jacques.
Yes, just a final comment on Tania's point. If I may just use a case example of Ghana, for example. Ghana has a national drone program, which I think is the first in the world. And it's got satellite locations at different parts of the country for delivering vaccines and medicines to the rural community. So it's possible to leverage a program like that, the Ghana National Drone Program, with the on-the-ground immunization models, which most of these countries have quite a solid immunization program, given that, measles and polio and all those infectious disease of the past. So I think it's possible to mix both a digital health strategy, like the drone program and other programs, and in conjunction with, programs that are already known to be working very well, like some of these immunization programs, when it comes to COVID.
Many thanks. So maybe just, other metaphors or examples from your previous experiences when we're thinking about vaccine delivery. Tania helped us think through the actual distribution of the product, vaccine verification, how do we ensure the individual received not just the first dose, but the second dose. And just of note for the general audience here, what we know about the vaccine portfolio is that several of the vaccine candidates, some will require a week in between doses, some will require 2 weeks. And likely each government will be procuring different portfolios of the vaccine. So you may be informing your workforce, X number of vaccines need 2 doses within 7 days versus 14 days, and then second generation vaccines will come and then disrupt those instructions as well. And just to tag, I think, Tania, your third point really was in the sense on the demand side, how do we ensure vaccine literacy, understanding that the origins of vaccine hesitancy right now are very diverse. The information, the infodemic that people are receiving, how that's being consumed. So I want us to take a step back for a moment to think of what are other solutions we're seeing out there to help resolve some of these bottlenecks that we'll see ahead in vaccine allocation, distribution, verification, and then demand the vaccine literacy for the COVID-19 portfolio.
Yeah, maybe a couple of more ideas and areas. I do certainly think training of healthcare workers. I think broadly this is something that is ripe for innovation. If we're going to close the gap in terms of healthcare workers on the continent, I think that the digital education is an absolute must for innovation. And this is a unique opportunity to actually start testing, because if we are imagining a world where a country may receive one vaccine and we need to train thousands of healthcare workers in using one type of vaccine. Maybe it's a UCC that require prep time, and how do you train around that? And then literally within maybe a couple of months or 6 months later, the country will receive a different type of vaccine. Then we now need to go out and train the same healthcare workers on a new vaccine. If we use the same old ways of doing that, where we call people into trainings, we pay per diems, people stay for multiple days, we will never get the job done. We will simply not be fast enough. And so how do we move some of that training onto digital platforms and so forth to do it much faster, much more cost effective also? It's going to be a huge cost, and maybe there will be some support coming in from the ACT Accelerator, but I think there's certainly going to be an expectation that many of the countries themselves will need to carry a lot of the costs as it relates to the delivery of the vaccine within the country. And a second area that's exciting, as Jacques was also mentioning, he talked about the drones, but I think the broader supply chain system, everything, from monitoring to ensure the integrity of the supply chain, there are great technologies out there that allows for remote monitoring of the supply chain, and all of a sudden we might need, everything from 2 to -20 up to 80. How do we ensure that integrity so that we actually know the vaccine we're delivering will be effective, and we can't afford to have high wastage rates? But also, where is the vaccine? How is it being distributed across the country? The trucks, monitoring all of that. There's great technologies there. And what is exciting about some of those technologies is that it's not just, of course, for the government to buy those technologies and use themselves. This is where the private sector can play a huge role. There are great transportation logistics companies already operating on the continent. And so it's a matter of also government strategically engaging with the private sector and using this as an opportunity to encourage them to make some of the investment into some of these technologies, so that it's not solely expected on the governments to be buying and be financing new technologies coming from investors and so forth.
Many thanks. We're having a flow of questions and response. I want to make sure we just spend a few minutes, because this topic is one I know that's important to all of us, about privacy. So if we think of, we're acknowledging we want the data flows to be available for prediction, for planning, for implementation, and then at the same time, the data itself of identifying each individual and verifying they received the vaccine is data that the patient and the individual should own themselves. And curious to get your thoughts about how will we protect the data, the complexity of this data, where we typically don't have this level of data on routine immunization records. Curious kind of bottlenecks you see ahead and solutions to this issue regarding privacy. Jacques, maybe I'll pass the baton to you.
Well, thank you, Rebecca. Privacy and security is huge. I don't know that we have an entire answer as to how we're going to solve it, but I believe governments are going to have a national strategy, a digital strategy, where most of the data is stored in country and not outsourced, outside the country. Secondly, there are technologies like blockchain, which, it's still early, in its development, but blockchain enables more privacy and has more privacy and security features. And I believe that if we build some of these digital tools around that kind of technology, it might alleviate some of those concerns that we have around privacy and security. And lastly, I would say that when it comes to a pandemic, I think we have to give off or trade off some of those concerns of privacy and security, because at the end of the day, a pandemic like COVID-19, where there is no vaccine, I think should take, precedence over, minor privacy or security concerns that we may have. So,
Eugene, would you like to respond regarding privacy?
Sure, thanks. I'll add a quick just thought on the previous drone comments. And you know where I'll go with these. I mean, to me, it all comes back to historical and structural legacies. But I've worked in places where the drone lands and delivers the blood and vaccine, and it's great. We have these things. And then I say to myself, "Where's the road? We didn't need this if there was a road here." But roads would require loans and resources that have been taken previously, whereas the drone things, well, we have an NGO that's has brought the money for it, and so here's a solution to make up for what is really a structural historical defect. And so moving on to the idea of collecting patient data and information on a big scale, I see something similar. I see it as a new extractive economy, right? You're going from the old resources to more of a biopower regime where, you're taking people's details and, are they getting a lot in return, right? Maybe they get the vaccine, but they also get more control. So for me, these are very, they're fraught, and it's hard to answer them without an eye to the structural legacies. And I think they actually, divert attention from them, because they're sort of gloss over solutions. Like the drone is a solution for not having roads or an actual, travel infrastructure. And the collection of phone, using phones to deliver vaccines kind of tries to repair legacies of mistrust that you'd be better off repairing than actually trying to fix with these new things. So, I just wanted to sort of present the other side of, there is the promise, but there's also the potential negatives.
Maybe just to add on to it, and fully agree with everything said, I think what to some extent also make me hopeful as we think about the COVID is actually the presence of Africa CDC. It is a relatively new organization, but it is an African directed, empowered, and so forth organization with a direct link, frankly, to the heads of states, and with very strong scientific leadership with a deep understanding of these topics. And so, I think it's a topic that needs to be discussed within an African context, and they will be very well equipped to actually lead that discussion. And then the second thing on the topic as it relates to it is that think about civil society. And we have a history of strong civil society, specifically focused in around certain disease areas. But as we think about COVID, what is the civil society that should and is emerging around this pandemic that we're in, and how do we get them to be part of these conversations, but also to hold our leaders and the various tech companies or other companies that may be involved in terms of collection of data account to the different principles or agreements that are agreed upon within a local context. And that's certainly something that people can think about, funding those ones, but also, frankly, engaging the youth, given that we're such a young continent, and they have a deep understanding of the technologies and a kind of many raised with using the technology. And that in general will actually also then get a completely different audience engaged into healthcare, which is the one that is unfortunately often not that engaged, especially as we think about the adolescents and so forth that are at risk for many other reasons. So I think there is a bit of a multi-sectoral approach here also, and a multi-generational approach that we can take when we think about these solutions that are beyond just regulation, which is of course needed.
Many thanks, Tania. So there's so much we could dive into any of these dimensions in a full hour. I'm also acknowledging we have a wonderful group of audience members here, and we'll just spend time on a few questions. So thank you for asking. I'll just repeat them here. One of our audience members asked, would you recommend the review of the evidence supporting different digital health interventions currently deployed in Africa in order to inform decisions and country investment plans? And I might expand that question to say, do we have the evidence base needed to inform the investments ahead in the midst of a pandemic? Jacques, maybe I'll start with you.
Yeah, so thank you. So as you know, the pandemic has been with us for a couple of months now. So I don't think we have, that kind of data based on the pandemic. But what I will say is that, for example, we just applied for a grant to do a remote monitoring of hypertension using a remote monitoring app. And what we've done is we've co-created it within the local community. And we are using community health workers, for example, to administer the app, to collect the data. And we're doing it a pilot both in the rural setting as well as in the urban setting, using app-based and text-based data. So this is a pilot that's going to go on for a number of years, 2-3 years. And we hope that once we've collected enough of that data, we can then partner with the National Health Service to be able to scale. So I think a lot of these pilots or these new technologies need to go through that phase of piloting to see what works, what doesn't work. And then based on the data collected, you can reiterate that digital health tool. And then the national health system can then take it up and then scale it. So I don't think it's as easy as bringing the technology to a country and saying, well, we've done a few tests here and there, and now we want to scale. Most of those really eventually do not work because of the uptake of that technology. So I think there should be a very well-structured plan when we start to use some of these technologies in country. And then the last point I want to make is that as we start to look at massive investment, especially in the vaccine space in Africa, it's also important to note that there's quite a number of very well-trained diasporans, African diasporans in the US and in Europe that have the skill set to either create biotechnology companies, pharmaceuticals, vaccines, right on the continent. So if we were to spend some of those investments on African scientists to develop some of those technologies right on the continent, I think we'll make a lot of headway in adopting those for the continent.
Many thanks. Tania, would you like to join?
Yeah, the one thing I will add is, so I'm a big believer that we've never seen more attention on health, perhaps in Africa, than we currently have from a very broad audience. We're also seeing an influx of money, locally spent, also domestic financing, as well as international from the outside coming in. And I think it's really important that as we deal with the pandemic at hand, we're also thinking about how do we make those investments sustainable for the long term. So, not everything, of course, should be isolation tents because they need to go down and then they're no longer there. But, how do we actually make investments into things and infrastructure and skills capability that will stay there for the long term? And so when I think about digital health, one of the things that strikes me is that we are in the process of setting up the African medicines agencies. Very important, and probably has been going too slow, frankly. And it's an important piece in terms of in broad and in general ensuring access to medicine on the continent in a timely manner to new innovation and everything. But then when you look at something like the FDA from the US, they just, I think the other day, yesterday maybe, announced that they were doing the Digital Health Center of Excellence. And then I think to myself, how do we set up the African Medicine Agency to be forward, to be future looking, and not model on what was there in the past? And for me, that means, should that have a Digital Health Center of Excellence? As we think about digital therapeutics, should that be a clear piece within the AMA, so that as and when these innovations come, and we're actually ready to adopt and use them and get them into the country, but with a clear evidence base, protecting people, making sure that we're not putting apps in the hands of people that might actually create harm if we are unlucky, and at best just be neutral and provide some sort of placebo effect, or perhaps whatever it may be. So I think that's important. So do we have the clear evidence now? Well, for some things, yes, we're trying, but we also don't actually have the structures to allow us to quickly evaluate and then send them back into countries and say, hey, we, Africa, have looked at this, these are digital, they're passing these and these and these criteria that do we believe are correct. So I would encourage us to really, build some of those institutions, invest behind those institutions now that we have the attention from heads of state and many others, rather than letting this, what is a tragedy, but also, a unique opportunity, frankly, to attract investments into health that we need.
Many thanks, Tania. Eugene, would you like to respond?
Thanks. So very quickly, I'll just say, because I was looking at some of the other questions, my views on reparations come more as an ally and a convener of the Commission on Reparations. The things that I've repeated, actually all the sections are led by people that would be receiving those reparations. So our sections on Africa, one's DRC and one is South Africa, are led by a South African and a Congolese skull activists. And I'm just repeating things they have come up with. I'm not speaking on behalf. My work, I actually, since I roll in the the halls of power, I try to document how harm doers do their harm, not what it's like to be on the harm doing end. And so what I'll say about where I've been recently in the Africa CDC, the vision is, the continental vision is brilliant, and it's not new. It goes back further than Kwame Nkrumah in the 1960s. But what I've noticed is that there's still, despite the health ministers meeting in February and developing a continental plan for COVID, there's still this piecemeal American universities, NGOs trying to partner with local ministries of health to get studies done. And so, for example, we're trying to organize national serosurveys across the continent. And what we're finding is that there's already what we might call interference from whether it's an American university or an NGO that's already purchased serological kits that are inferior to the ones that we're able to get. So there's still an interesting dynamic that needs to be sorted out on the organizational level. And it, again, like I always say, it comes back to not just the economic capital extraction, but that academic capital extraction is a big deal.
Can I make a comment to?
Yes, please do.
Yeah. So I'm sure you all know about the AFTA, right? The African Continental Trade Agreement. So if I may suggest, now that we have an African CDC, perhaps the African CDC should take a much more leading role in terms of the regulatory aspects of whether it's technology, whether it's medicines, whether it's vaccines, and that because of the AFTA, the African CDC, in collaboration with the country CDCs, make those decisions on whether it's a digital therapeutic, whether it's a vaccine, or whether it's a new technology. I think that might help alleviate some of the concerns that Jean has brought up. With each country or each organization trying to do their little piece. But I think we need to have a coordinated African-centric approach to how we do this.
Well, many thanks. We just have 3 minutes to wrap up in this. You can see where we went and so many different dimensions to this conversation. And we actually also have our poll results. And I just wanted to remind us, we kind of sparked this discussion. There was a report in The Lancet in April, and the authors recommended to make digital health flourish within sub-Saharan Africa, enabling environments needed to be created, firmly anchored within the local context, driven by African needs, endorsed by decision makers such as national governments, and supported by global key players. And we mentioned several of them today. And that work ahead of establishing the delivery ecosystem and investing in the delivery ecosystem alongside discovery and development, we pointed to several of those implementation bottlenecks today where there is not the investment for the workforce, there's not the investment for the software architecture per se, and the co-creation, as our panelists have mentioned today. We did want to get a sense of your current practice, and here are the results of our panel. Have you used a digital health or telemedicine provider since the start of the pandemic? 46% of our attendees said yes, 54% no. And we'll be curious to kind of march this out over time, if this becomes a preference versus an offering that falls to the wayside post the pandemic. I also just wanted to kind of end on a note in the midst of the disruption of all of our lives, of why we need this type of leadership that we've seen on this type of panel. There's an author named Dan Heath who talks about upstream leaders, and he says, to succeed upstream, leaders must detect problems early, target leverage points in complex systems, find reliable ways to measure success, pioneer new ways of working together, and embed their successes into systems to give them permanence. And I do think this is our challenge ahead. It's not necessarily a digital tool, a training modality, a financing mechanism, but truly the systems ahead to secure, obviously, our routine immunization, pandemic preparedness for future pandemics, and strengthen the workforce that comes to bear. So I wanted to thank our panelists today, Tania, Jacques, Jean. Thank you for joining us and carving out the time. Thank you for all of those who've attended. And thank you to the Center for African Studies for sponsoring this seminar. The next webinar will be the current state and priorities of COVID-19 in Africa. You can go to africa.harvard.edu to sign up for the newsletter. Thank you for also filling out the post-webinar survey. And very much thank you to our student interns, Daniela and Reddit, for assisting with this webinar. Thank you everyone for joining us today. And we appreciate the dialogue.